Morning. It's a real pleasure to be here. I'm an anesthetist or an anesthesiologist and intensive care physician. I live now in Sydney, where I've been for the last 2 years, but originally from the U.S. What I'm going to talk about today is a dramatic, different twist than what Cliff talked about. That was a great talk, Cliff, and it's good to see you again. I'm going to talk about all the stuff that we know causes harm, and I love the framing before about critical care essentially being an iatrogenic illness. I think it's a wonderful place to think differently about organizational change as well as physical design. So I'm going to talk about the physical design of the ICU, the bricks and mortars, the architecture. I'm going to talk about some of the organizational design, and then I'm going to try to connect it to some tools. We flip-flopped our talks. I have a follow talk which will be about tools in the ICU, so I might be touching on things that I won't have time to talk about now. So what's very interesting about ICUs, in addition to all you've heard, is there's a huge amount of information, a lot of technology, a mortality that is usually around 33%. So this is a target-rich environment for reducing harm. There's no question about that. Usually expensive, as was alluded to earlier. Major fragmentation. A huge amount of costs in most systems is in the last 30 days of life. So again, the ICU features as an incredible political target for reducing costs, and a huge amount of interdisciplinary and interdependent work. Now, these are complex terms, and I'd like to unpack them because we assume that groups of people that work in the same space are actually interdependent or actually a team, and I would argue that, in fact, many ICU teams don't adhere to basic definitions of teams. They're all working around a patient, but they actually have very little interdependency, which is defined by a shared goal, shared learning, shared finance, shared feedback, shared debriefing. And so this is really a different way of looking at some of the adverse outcomes. We also know that ICUs, of course, were not around until these types of patients that were alluded to earlier, the polio, the war injuries. The hallmark was technology to save the patient, to allow time for the body to recover, and obviously to find other homeostasis mechanisms that would allow vital functions to pick up while not causing more harm. The wellness model, which I'm going to approach around the organizational approach, or so-called the salutogenesis, suggests that the environment has a huge impact. So here's a question for you. How much does your physically designed ICU influence the mortality of your patients? Does it, first of all? Do you actually think the physical design? Or let me put it differently. Could you get the exact same outcomes irrespective of where the ICU physical plant is? No?
Well, it must be near some other facilities.
No, but if you moved it from a basement to another unit to another place, is the physical environment?
It is important.
So this is an interesting question because there's not a lot of research. There's a little research, but it's a very interesting question about how the environment, and in other spaces, the environment is felt to contribute about 25% of organizational outcomes. Now, we know in the ICU, of course, that light, we've known that for about 25 years, is directly related to how much sedation you need to do so-called sundown psychosis. We've known that for decades, and yet many ICUs are still in basements. And yesterday, we had a wonderful discussion at dinner about, well, if you have no choice and you have to put your ICU in the basement, and I would pause and say, well, that would not be a not choice. So if you put an ICU in a basement when you know that natural lighting directly influences the well-being of the patients and the providers, you'd never actually put an ICU in the basement. But that's, and we've known that for...
Basement, you mean underground?
Literally underground, yes. So natural lighting has a huge impact on circadian rhythms, on neuroendocrine rhythms. We know it very clearly. There's some work suggesting that natural lighting influences the well-being of white cells. They work better when they're influenced by vitamin D through natural lighting. Now, there's some growing research, it's not very strong, suggesting that these aspects have some impact on the outcomes of patients, things like sound, materials, art, texture, light. I raise that because there is this field called evidence-based design. It's a nascent field, and it tries to bring some of the rigor of evidence-based medicine into the physical design, the architecture, the engineering. Yesterday at dinner we talked about, David, we talked about color. So here's a question for you. How many of you know what the evidence is behind why operating rooms have a green color? Does anybody know of any evidence why we paint ORs green?
Repeat the question.
Why do we paint operating rooms green?
It has something to do with the blood, I think.
Nope.
No.
Nope. So here's the easy answer is that there's no evidence. The evidence comes from submarines, where eyes that are fatigued, you move from a red lighting system to a green lighting system because green light tends to be less straining on the eyes. That's how ORs became green. That's the level of rigor that we've applied to the physical design of our operating rooms. My point in raising that is not to suggest that we shouldn't be doing that. It's to realize that a lot of these basic things are based on case studies of one, or sometimes not even that. Now, when we look at harm, this is some work we did several years ago in which we looked at low reliability systems. This is bungee, microlight flying. David, I hope you don't do microlight flying. I heard you're a pilot. But so aviation, of course, comes from here, 10 to the minus 6, 1 in a million, to microlights, which crash about 1 in 200, or Himalaya mountaineering that die every 75 assaults. So these are low reliability systems. These are medium reliable, and these are very highly reliable systems. ASA-1s, according to most data, would suggest that about 1 in 100,000 today, although there is an interesting argument that Bob Lagasse makes that, in fact, we're not over here. We're actually still over here. Nothing has changed in 40 years. But when you look at ASA 3 to 5, and as a cardiac anesthesiologist, we still harm about 1 in 100 patients. And if you're in the pediatric space, it's about 1 in 25. This is state of the art today. So this is a reliability chart, and it's meant to try to encapsulate the reliability or the ability of the system to function according to its design. As Cliff alluded to, these are driving all over the world. The amount of healthcare in the GDP is up to 18% in the US. In Australia, it's 14%. In the UK, it's climbing to 16%. Huge variation, huge costs. And politically, it's not acceptable anymore to say this is the cost of doing business. The end result is rationing. And that's what's happening all over the world. In some countries, you can use the term rationing. In the U.S., you're shot if you use the word rationing, so we can't really use that word. But we are rationing. We're actively rationing because of the incredible costs. And of course, the Institute of Medicine has made all these recommendations, and we'll talk a bit about that. So this is what quality is defined today. It's defined as this composite, which is made up of efficiency, effectiveness, safety, equitableness, timely, and patient-centeredness. The question is, can we measure this? And how much of this goes into our overall outcomes in the ICU? Or to put it differently, if you had the ability to put on one graphic the cost of care in your unit, the satisfaction of the patients and the family, the outcomes, and the flow, one, could you do that? And two, would it allow you to make a case for why you need to invest more in ICU care? We call this the clinical value compass. And essentially, by bringing these four streams together, we're making a case. We're also making it very clear that we will not put more money if the outcomes aren't improving, or the satisfaction of the patients isn't improving, or the overall flow is not contributing to the larger system. So when you map out risks, of course, you have to come to this study. This is Peter's study, Peter's Pronovo study, showing that central line infections were reduced in ICUs in Michigan. You're all familiar with the study, right? Now here's the most amazing thing. This is the intervention. I want you to read it briefly, and I want you to wonder for a moment, what's wrong with this study?
Well, almost everything.
Now, this is not rocket science, to use a very bad metaphor. I mean, this is something that anybody is taught in medical school, but this was the intervention. Now, the fact that they were able to get an 80%, over 18 months, a 66% reduction by simply doing that, we need to step back from all the interleukins and talk about some basic mechanisms here. We call this normalized deviance. If 66% of reduction of mortality is directly, or sepsis is directly related to not following basic protocol, why don't we just pause and look at how much mortality we could prevent by simply adhering to things we've known for quite some time? Now, this study is another fascinating study because it never got ethics approval. And Peter got slapped on the wrist because of that, and it's challenged the whole U.S. research system. But it's another interesting question about, is this research or is this quality improvement? I'm sure many of you, particularly in the U.S., have to struggle with that when we do interventions. Is it research or is it not research, and do we need to get approval of patients? I mean, would you ask the patient approval if you should wash your hands? I mean, that's the interesting thing. At dinner yesterday, we talked about a study that we did recently. We measured how often do anesthesiologists, surgeons, and nurses wash their hands when they come into the operating room. Not surgical prep. How often do you think they wash their hands in your hospitals? What do you think? 10%? 30%? 40%? What did David say? No, you said something else at dinner yesterday. What did you say? This is important. That's what he said. 0%. We found 11%. British Journal of Anesthesia last year, when we tried to publish in the BMJ, they said, we don't believe this data. It's impossible. When you go back to your hospitals, just pay attention. Watch the OR and see how often people wash their hands. You'd be surprised. Then we looked at how often people wear gloves or wash their hands before they put in IVs, intubate, NG tubes, Foley catheters. And it ranges from about 20 to 40%. Again, these are people that are taking their scrubs home, coming from the cafeteria or from the bathroom into the OR and just immediately touching the patient. Does that sound surprising? Can you appreciate that that's a common phenomenon? So this is a term that psychologists call normalized deviance. But this concept of the fact that when I trained as an ICU fellow 11 years ago, every unit used to have 2 or 3 patients that had a central line infection. Now there are units that are reporting 200 days without one infection. Do you believe that data? Do you believe that data? So we've gone from it's impossible not to have central line infections to now having 200 days without one infection. It's a very troubling change. You can't just explain it by something. You have to peel that back and realize that this really goes to the culture of how we behave. Because if we taught people, we socialized them that it's common to have central line infections because that was the culture, suddenly now we can go 200 days without. And there's a lot of skeptics who believe that, in fact, it's not possible to go without an infection over 200 days. Something's fudgy with the data. Perhaps we're not measuring it properly. Perhaps we're not cultivating the relation to that. So we call these mental models, and what Peter Senge says is that what you think are your hard beliefs are not really hard at all. What they are your senses taking in subjective information, filtering it through what you were brought up, and then you say, these are my beliefs. The reason why this is important is because when we try to change people's behavior around giving antibiotics or washing their hands or washing their or preparing for a central line, it's very, very difficult to change their behavior without understanding why they do what they do. Why do clinicians still not wash their hands more than about 30% of the time in several international studies? Why is it so difficult to get them to wash their hands? Jim Reason talks about this, which is when accidents happen or harm, it's always management. So the head of the department, the CEO of the hospital, they're responsible for all harm in the hospital. Not directly, but by creating the conditions that allow clinicians to do what they do. Clinicians make mistakes all the time because they're humans. It's not a question of, will they stop making mistakes? The question is, can we design a system that attenuates or stops the errors from propagating to harm? This is work from the US, from Europe, from Israel, from the Netherlands. It's been replicated now in about 14 countries, and it seems to suggest that it's clear, for example, that when you use checklists, and how many of you use checklists before surgery? Timeout. So checklists, according to Atul Gwanati in New England Journal of Medicine, in developing countries, reduced harm by about 1/3, death. But in non-developing countries, so countries that have developed already, it only improved by about 4%, which is interesting in itself as well. Now, when they repeated the study that Peter Pronovost did in England recently, the checklist in the ICU, they found no improvement from the checklist. None. This hasn't been published yet. And what's very interesting is Mary Dixon and Peter Pronovost wrote another paper this year in which they asked the question, why did the checklist work in Michigan? And it's interesting because you might think that it's just a checklist, but what they argue very convincingly is that it wasn't the checklist itself, it was what the checklist allowed, which was engaging the team members to actually talk to each other and communicate with each other. And the reason in the UK why it didn't work is because the NHS forced it on several hospitals, whereas in Michigan, all the hospitals were coordinated through the Michigan Hospital Association, so they volunteered for it. So the engagement of the clinicians had a huge impact on the success of the intervention. Now, when we talk about a randomized controlled trial, a good result is 4%. Cliff, would you say that in a good randomized controlled trial? Okay, 4%. 66% reduction by simply having a sterile intervention of a central line. That's it. Versus 4% after 5 years of a huge control mechanism. So there's a lot we can do right now to improve based on things that we know already, which are not based on, I'm going to skip this right now. So what many people suggest is that when we design a system, and the ICU is common, and Yoel Duncan showed that years ago, is that 1/3 of the patients are harmed because of things that are totally preventable. From miscommunications, from handovers of care, from medication misadministration, from lack of shared mental models. And so this is other work that we've done in which we've looked at cardiac surgery, in which we've demonstrated clearly that these things, and they apply to the ICU, the organization, the environment, the task, and the patient, are hugely responsible for causing at least a third of the harm. A third, 33%. So when you look at all this data, it's clear that just stopping right now in the ICU and implementing things that we know that work around these things could probably prevent maybe 15% of mortality, maybe. Maybe because the larger studies have not been done, so it's based on extrapolation. Let's talk a bit about design. So we talked about the technology, a huge amount of technology, lots of real-time sensor arrays, companies driving, and the ability to really have an entire laboratory in the ICU. Now, of course, the cost has gone directly related to the technology, and the reason why the ICU is so expensive is because it's a huge addict to technology. And so then the question is, are ICUs cost effective? Are they, in your mind? Do they produce value to the public? If you think about it, in QALYs, quality of life saved, which is a measure that all Western systems use, are ICUs cost effective? And it's a tough question in front of intensivists to ask that question, but in fact, we're forced to answer that question. Given how much it costs, is that the best way to spend our limited resources? Again, another nice way of rationing at the end of the day. Now, the buildings itself are very, very expensive, and the ORs and the ICUs are the most expensive spaces to build in hospitals. And one of the reasons why they're so expensive is because of the complexity, the density, all that goes on in an ICU setting. Workforce issues are obviously driving a huge part of this because we know that there's a huge ICU nurse shortage. There's a huge amount of turnover. It takes quite a while to train an ICU, both intensive and nurse. And so in most countries, intensive nurses or physicians are greatly lacking, which means that we have to turn towards technology. And technology is going to solve our problem, VisiQ and other things. And that raises some and other important questions around what is the role of the clinician at the bedside versus over a monitor or not actually being physically part of the team. Now, a lot of people have focused, this is work that we've done on designing teams for ICUs. It's called Team Steps. It's a program that's been out for a few years. And it focuses on the fact that teams in the ICU function better when they trust each other, when they have a shared mental model, and they communicate well. Not rocket science, right? But these are the only three things that have been shown by hard evidence to actually make a difference in team training. How many of you actually train your ICU teams together as a team? I'm sorry, let me ask that once more. How many of you actually have a way to train your teams together? You know, like musical teams, sports teams. Does anybody? Okay.
Well, training comes from comes mostly from the other guy, the guy near you. A young doctor learns from an elder doctor.
Right. So that's an apprenticeship model, and that's a very powerful model. But in all industries, they've all moved away from the apprenticeship model to build on that onto a team model. Because reliability in systems is not based on individuals, it's based on team models. And ICUs are no different in many ways. But yet, we don't do team training in our ICUs at all, which is amazing in itself if you think about it. So traditional ICU design really did not address fundamental experiences of the patient. So ICU patients have complained for decades about the ICU being lonely, isolated, metallic, noisy, impersonal, not a place to heal. And so how much of that contributes to the overall depression, extra sedation. We know that patients that come out of ICU, I think a third of them have post-traumatic stress disorder. They can't sleep well for months. They can't be alone at night. They have serious problems adapting back to society. So we get them through the RDS, but then they're emotional cripples for life. Is that good outcomes? So again, after we've learned the mechanics of keeping the patient alive, we need to start thinking about how do we get them home so they can function again, they can work again, they can deal with the dropped foot, they can deal with the fact that they're alopecia because we didn't protect their head. These are things that cause great distress to patients, undoubtedly. So older designs, of course, lack space, poor access. Last night we talked about, if you design an ICU room and the sink is behind the patient's bed, do you think that will influence the compliance of clinicians to wash their hands? Well, very clearly, and I'm going to show you the evidence in just a moment. So from some other work that we've done recently, and this is a health policy question, if you wanted to change the outcomes of patients in the ICU, you could focus on interleukins, you could focus on organizational culture, or you could focus on physical design. As you move from left to right, you multiply. So this is a 3% improvement, 20% improvement, 50% improvement. So this is the fundamental rule of structural targeted interventions. The higher you go upstream, the more impact you have on the system. So this is, again, an argument to talk about the physical design. Now, the problem with the physical design is that we don't have a lot of evidence around, certainly not in a biomedical perspective, on how to physically design. For example, how big should an ICU room be? How many beds should an ICU have? How close should it be to other places? Where should the clinician sleep? Is it important that the nurses can see the patient's rooms? And these questions all by themselves might seem rather simplistic, but when you're trying to build a new unit, you need to ask your question, what is the best available evidence, and how do you actually physically design the space? How many of you have actually been part of designing a new ICU? Okay, so maybe 1.5 hands. So again, that's one of the challenges. Most of you will only be part of maybe one new ICU design. So guess who's building the ICUs for you? Non-clinicians, architects and engineers who come to you, listen to you, and as I asked David yesterday, when he saw the ICU in the hospital, what did you say? It was nothing like what we had said. They took out most of the things that we wanted. So again, the challenge is how do intensivists influence the physical design when a lot of it gets value engineered out? So here's an experiment that was done in Houston in which they looked at the location of, this is a non-water-based gel for hand washing, and the only difference was either the gel was either on this wall or on this wall, 6 feet away. 30% difference in hand washing before you touch the patient if you can see it. Out of sight, out of mind. That's it. Simple study. So they would come from the OR from here. If it was on this wall, it was about 60% hand washing. On this wall, it was 30% hand washing, which is very interesting about how we clinicians work. We have a cue, we respond. We don't see the cue, we forget to respond. Here's another study in which they looked at old and ICU configurations, and they looked at the placement of the sinks and the placement of the gel dispensers. And what I'm going to show you in a moment is how placing it either at the inside of the door, in the corner of the room, or next to the bed dramatically influence the hand washing compliance of the clinicians. And you can imagine this is a very difficult thing to actually, so you can see here's where it was before, where the sink was outside the room. And then they actually put it here. They put it where the nurse was actually right next to her logging station. And then here you can actually see what it looks like in real time, where you can see that closest to the patient. So it was right here, right next to the patient. So the patient can see it, the family can see it, and the clinician sees it when they walk into the room, right there and then. So there's that point accountability, if you will. And so this is a dramatization of what happens when you're walking into it and you actually see the sink as you come to the bed as opposed to otherwise. Well, here's what the data showed. So the data showed that with an open bay, old ICU bed versus the new single room, they had a 74% increase in hand washing. That's it. The physical design alone. They did no other intervention. Now, we know from other studies, for example, this is Walter Reed 25 years ago, that by altering the amount of lighting, which is measured in lux, the amount of lighting over the nursing station can halve the number of medication errors by ICU nurses. That's it. By just changing the amount of targeted lighting. Now, yesterday we had a discussion at dinner about maybe around medication errors in the ICU. Maybe we should get rid of nurses actually preparing drugs in the ICU. Maybe they should be unit dose. Has anybody moved to that yet? Well, the literature shows clearly that pharmacists are much, much safer than all other beings in the world in delivering medications. We know that very clearly. We know in ICUs that having pharmacists reduces sedation, reduces ventilation time, reduces adverse events. So that's another issue where, again, the external environment, not the drugs themselves, but how the drugs are delivered to the nursing system will reduce the medication errors by about 50%. Let's talk a bit about noise. This is John Hopkins measuring the amount of noise in ICUs from 1965 to 2007. This is 40 decibels, and this is 70 decibels. Just to give you what that means, 70 decibels is almost equivalent to a jackhammer. Okay? So this is loud ICUs. And this is a natural progression because of technology. There's no question about that. Now, one of the things that we know from the research is that noise disrupts clinicians, causes errors, increases the blood pressure of doctors and patients, perhaps also increases the ability to rest, impairs speech recognition, disorientation. These are all evidence-based. And in babies, very clearly, that directly related to sound, this is what happens. 50 decibels versus 30 decibels. Lower oxygen saturation, higher respiratory rate, higher blood pressure, faster heart rate, impaired sleep. So neonatal ICUs are dramatically being designed differently. They're quieter, the sound is muffled, and because of this physical environment, of all ICUs, the neonatal ICUs have gone the furthest in incorporating environmental and physical design. Here's an example. This is Sweden. This is looking at what happens when you have a code and when the sound from the ceiling tiles don't absorb the sound, so the sound waves reverberate. And what happens is that a lot of the orders gets lost because they're masked by the reverberating sounds. So imagine if you're in an echo chamber and everybody's yelling out that you can't hear very well. And if you have foreign accents, it's even worse. And what they showed in Sweden was that by changing the coefficient on the ceiling tiles, which cost 3% more, they were able to improve not just the satisfaction, but they felt the overall utility of the team. And this is at the Karolinska. And again, there's a lot of acoustic research that's gone on around this. I don't have time to go through that. This is some work that we recently published in which we looked at the issue of alarm fatigue. One of the biggest topics right now in the U.S. Is a growing sense that close to 500 patients have died in the last several years in the U.S. because of what's being called alarm fatigue. And the case that made it famous was a case at Mass General 3 years ago in which a patient who'd had a chronic respiratory patient, and of course, because of their trach got plugged, the alarm kept on going off, so they finally turned off the alarm, and this time it got disconnected and he was found dead, right? We've known alarm fatigue for decades. We know clinicians ignore alarm fatigue. We know that in the ICU, I know of a case in San Francisco in which coming off bypass, the patient essentially died because they forgot to put on the ventilator because there were no alarms. And we regularly turn off alarms in anesthesia. In fact, that's part of how we train people. And Iran yesterday was telling me about something that some people in Haifa have worked on, in which they've been able to design a complex alarm that monitors what's happening post-bypass or peri-post-bypass, so that you get a special signal you need to turn on your alarms back, because clearly we've taught clinicians to turn off their alarms because the ventilator companies, the OR, have refused to design alarms that would adhere to the different profile of what a patient looks like post-pump as opposed to on-pump. So as it turns out, one of the key problems, this is Hopkins again, they were able to reduce the number of false alarms by 25% by simply reducing the thresholds of the alarm. So the devices come with pre-programmed alarm alerts, and sometimes because we measure multiple types of blood pressure, we can have 6 to 10 different alarms just on blood pressure. Systolic, diastolic, mean, non-invasive, invasive. All these alarms have to be addressed. So at Hopkins, they decided to have somebody who actually went around and just turned the alarm threshold down by 20%. So instead of the blood pressure being at 80, it was at 72. That simple thing reduced the number of false positives by 26%. So again, this is the environment around the patient. So some new ideas around design are suggesting that, of course, how do we design the unit to incorporate the wellness of the patient and the family? So should, for example, families be allowed to sleep in the ICU? So in the pediatric ICU, there's no question anymore. All new pediatric ICUs are all designed with patient family spaces. Is there room in adult ICUs? Should patients and families be allowed to come on rounds? Should they be allowed to be in codes? Some very interesting questions which have a physical constraint, because if the room is very tight, you don't need more people there, and you don't need more noise and issues around that. But if you've ever had time to work with architects, here's how they begin. They begin with a schematic on a napkin. Then they start looking at future growth. How will the unit grow in the future? Then they start looking at the adjacencies, so the cleaning room, the clinical space, the diagnostic spaces, and then the ward space that will come in and out. Is it important who's next to the ICU? Should it be the OR? Should it be other spaces? Where should cardiology be, for example, in the cardiac ICU? These are tough questions. There's not a lot of good evidence, but it's clear that we need to be thinking about the relationships, not just the technology around it. The other key thing is, of course, the role of technology. And in most hospital designs, technology is not done until after you've already done the master planning. So the technology and the equipment gets done afterwards. And so there are units, for example, where you have fluids right next to electricity. And so it's humid, the fluid drops down, it causes shorts because it's very easy to put the fluid bar next to the electrical panel. So those are things that obviously should be done in the master planning phase, but that requires intensivists being part of the process. That means you have to be willing to give up several days a week to be part of the master team. And the master planning of a 3-4 year design only lasts about 8 to 10 weeks. That's it. The rest of the time, the designs are pretty much done. So I want to wrap this up by talking just a little bit about this. We've talked about lighting. We know very clearly about the fact that the access to barriers to hand washing. We know about the role and impact of nature. I'm going to show you just, this is a study that we did 2 years ago. These are sites looking out from an ICU, and we looked at the crankiness of nurses before and after a shift. If they looked at this, or if they looked at that. That's it. That was a study. And what you see here is that the nurse comes at 7, no view, non-nature view, nature view, how alert the nurse is in traditional validated psychological testing. And then we looked at acute stress, which we call the crankiness factor. How cranky was a nurse after an 8-hour shift when she was looking at a wall for 8 hours? And you'd be surprised. The narratives of these nurses is that they hate coming to work when the ICU window is a wall, as opposed to when there's a green space. 1984, a study published in Science showed that patients at post-general surgery exposed to a green space had 24% less VAS scores, less pain scores, less medications, got out of the hospital faster. So the physical environment around the patient had a big impact. So this is the other question, of course, around pendants. Should there be pendants? Where should they be put? How does that help clean the unit? These are very important questions. We don't really have much evidence around it, and yet we live around these things. And how many of you have ever knocked your head on a head pendant or struggled to get behind the bed because there wasn't enough room to intubate the patient? So these are physical constraints that need to be thought at as part of improving the overall outcomes of the patient. 2 final notes. Where should the nursing station be in the ICU? Should it be centralized or decentralized? And so we know from centralized nursing stations that the nurses spend more time in the centralized station versus near the patients. And so the flip of that has been decentralized nursing stations, but then the nurses are far away from each other. They don't get to socialize. They're more unhappy. And again, what are the optimal designs, particularly when you get to larger units? These are other important questions. I'm going to skip the art and all the rest. But here are some good final thoughts around noise. These are things that are now recommended around ICU noise: sound masking, active noise canceling, telemetry versus alarms, paging limits, Yacker trackers or Vocera, adjacent nursing stations, dampers on rattling keys, coasters on medication carts. These things all contribute to a huge amount of noise in the ICU, which we know keeps patients awake, annoys clinicians, causes higher stress, and overall reduces the benefit of the ICU. So I'm going to conclude by suggesting that the physical environment and the organizational environment is growingly seen as a contributory to a large amount of well-being and perhaps even mortality in many spaces, not just in the ICU, but of course because the ICU is so dense and because there's so much technology, acoustics, and those types of things have a huge impact. There's some research that just came out 2 months ago suggesting that if you coat the window covers in the ICU with copper-based materials, you can reduce VRE by about 15%. So these are heavy metals. So it took us 20 years to get heavy metals out of paint, right? Lead. And now the research is showing that heavy metals are actually very good at bactericidal, at least bacteriostatic and maybe bactericidal. So how much should we bring that into the ICU setting where all the surfaces are coated with bugs? And research is showing now in the operating room, for example, that the anesthesia tray, the IV pole, the ventilator keys, and the computer keys are full of VRE and MRSA. So how much of this physical environment then leads to infections to the patient, and how much should we include these types of elements in future research that looks at better solutions? So all these, you can find a lot of this in this is a book called The Guidelines for Hospital Design. In the U.S., every 4 years, intensivists and others come together to put together the guidance for how to design ICUs. This is used by 18 countries around the world as well as 50 states, and it's a very, very powerful tool and it's the best available evidence. A lot of it, from a Cochrane perspective, is quite weak, but is the best available evidence to design ICUs and to incorporate the physical environment into these considerations. Thank you.